You see this thing? This is called as utricle. It's a part of the vestibular system. This utricle contains a specialized structure called as macula. It's a very sensitive organ, so you should definitely take care of it. Especially this structure called as otoconia. These are just a bunch of tiny calcium carbonate crystals that's chilling in your inner ear. So never mess with your macula or otoconia. Oh no, the otoconia is in the posterior semicircular canal. Okay, so let's talk about benign paroxysmal positional vertigo. Now, what does it mean? This is a disorder. What kind of disorder? It is telling benign. Benign means it is not khatarnak. That means it is not dangerous. The vertigo lasts for a few seconds. What do we mean by paroxysmal? Paroxysmal means it happens now and then. Okay, beach mein or kabhi kabhi. It's not like it is happening continuously or every time. This happens due to if you attain or you are in a certain position which is triggering this event of vertigo. So that lasts for only few seconds, not like hours together or whole day. Okay, so benign paroxysmal positional vertigo it is not dangerous, it happens or it lasts for few seconds, the vertigo. Okay, then paroxysmal means it happens now and then, and positional because at certain positions only the trigger event happens and then there is vertigo. Okay, so just like few seconds ago you have seen that video of me jumping around here and there. So what is this? This is again nothing but the macula, and this is called the otoconia. Okay, so this is the otoconia, which are nothing but the calcium carbonate crystals. So this, what does it do? What is its job? Why is it here? So this is here because it gives certain amount of weight to this jelly substance. And it is not just these two things. There is also the semicircular canals, which has this another type of sensing organ that helps in detecting the dynamic motion. This was for the linear motion, this is for the dynamic motion. Linear motion is like you go in any one direction, straight or back, left or right, and this is like if you go haphazardly. Okay, now here I want you to understand this thing. Okay, these crystals of calcium carbonate, they are not like regular calcium carbonate, okay, like which is found in our bone. These are biomineralized, or you can also say these are custom made. Now what do we mean by custom made? Like we have the custom made bikes or custom made cars for special purposes, right? So similarly these crystals are also custom made. That means they are different from that of our bone cells. Now why am I telling this? Because when I will talk about the treatment, I will mention this point once again there. Okay, so let's talk about the pathogenesis. Now pathogenesis, as you already know, so there are these crystals. See, you can so there are these otoconia, the calcium carbonate crystals. Where are they usually present? They're present in the utricle. But maybe for any reasons, okay, let's go to the etiology. For any reasons, it can be of head trauma, okay, it can be of if there is any inner ear surgeries which disturb the delicate vestibular structures, or vitamin D deficiency, prolonged bed rest which causes the otoconial shift. For any reason, or let's suppose, what is this blue color? This is nothing but some kind of organic matrix. Okay, this organic matrix is holding down these crystals of calcium carbonate. Now for any reason, if that crystals of calcium carbonate or the otoconia dislodge means it comes out of that matrix, and for some reason if it enters in any of the semicircular canal, it can enter into any semicircular canal, but most commonly it enters into the posterior one. Why? Because we usually sleep in supine position, and when you take the supine position, the posterior semicircular canal lies exactly somehow like this. Okay, so because of this, the otoconia from the utricle, it directly enters into the posterior semicircular canal. See here, you can see this is the displaced otoconia. So calcium crystals, they come out of their usual place, that is from the utricle, and they enter into the posterior semicircular canal. That is most common. So what is big deal in this? Like, okay, it's just bunch of calcium carbonate crystals. What big thing happens if it enters into the posterior semicircular canal? Nothing big thing happens. That's what I am telling here. Okay, this is benign. Mostly the person experience vertigo. And what is vertigo? I explained in last video also. But vertigo is when you are standing but you feel the world is rotating around you, even though it is static. Even you are also static. But this is a kind of illusion. And why does that happen? Because of this otoconia. See, the first thing is it should be in its place. Everything should be in its place to work properly, like everything. But first of all, the otoconia is displaced from the utricle. That means the mechanism which this organ has to take place normally, that is hampered. That means the stimulations from these hair cells will be disturbed. So this is one thing. Second thing is these otoconial debris, they causes endolymph disturbance. Endolymph is what? Endolymph is fluid present in the membranous labyrinth. So this outer bony labyrinth, inside we have the membranous labyrinth. So inside the membranous labyrinth, because of this dislodged otoconia, it creates disturbance to the endolymph whenever you are moving in a certain position. And this works basically on the principles of Newton's first law, that is inertia. If you move forward, if you move backward or upward or downward, the fluid shifts momentarily backwards. So one side of the brain interprets it as positive, the other side of the brain interprets it as negative, and that's how they coordinate in a very coordinated fashion and detect the motion, position, proprioception and everything. Okay, so because of this disturbed dynamics in the vestibular system creates vertigo. So did we understand? We understood the meaning of the name. We understood the etiology, that it can be primary, which is nothing but the idiopathic. That means we are idiots and we don't understand what is happening. Secondary, because can be head trauma, sudden movement, which can dislodge the otoconia. Inner ear surgeries, if there is any inner surgery done, it can disturb the delicate vestibular structures. If you are in a prolonged bed rest, that means you are always in supine position, and for any reason, if the organic matrix degenerates, this can dislodge the otoconia. And if there is vitamin D deficiency, that weakens the otoconial matrix. Okay, so pathogenesis, I have told you, there is something for you. Okay, this is homework for you. The pathogenesis. These are just a bunch of filling the blanks and MCQs. Okay, every filling the blanks has certain options, and these are like USMLE level kind of questions. So I want you to answer all of this to check how much you are USMLE prepared. Alright, so the pathogenesis I have explained. So this is your job to do. Okay, so next we understood the pathogenesis. Now after understanding the pathogenesis, so we know that if a patient is coming with transient vertigo, like she or he is complaining that if she wakes up from sleep, then suddenly she feels vertigo for few seconds or like 1 minute maximum, then what will you do? What is the diagnostic investigation? So the diagnostic investigation is this famous Dix Hallpike maneuver. It is not DICKS. Okay, so don't get confused in exams. It is DIX. Now what is happening here? See, first let's see what's the maneuver. So there is a female patient and there is a male doctor. So every time you are in a situation where you have a female patient, always have a female attendant so that you don't end up into jail for any reason. Now next thing is, make the patient sit straight, then you go back and hold her neck and turn it 45 degrees. Then you make her lie down on the bed and make sure her neck angle with the bed is around 30 degree downwards. Okay, so what's happening here? When she is at sitting position, you can see that the otoconia is dislodged somewhere here in the posterior semicircular canal, but it is not entered like until here. Then when you turn it in this manner and you make her lie down at this position, the otoconia travels, like it goes into the posterior semicircular canal, as you can see here. Alright, so you will keep her in this position for around 30 seconds. After that, what will you see? You will see that her eyes is having nystagmus and she is feeling vertigo. That means, so will this happen in a normal individual? No. Why? Because their otoconia is not displaced. So why will that happen? But because she has a problem, her otoconia is displaced, and when it entered into the semicircular canal, it disturbs her vestibular system, the endolymph, the hair cells, they get disturbed, and because of this there is nystagmus. So what is Dix Hallpike test? It is used to identify benign paroxysmal positional vertigo a condition in which patients experience episodes of dizziness or vertigo, especially if the head and neck are moved to different positions. So we understood the steps. Turn the patient's neck 45 degree, lie down with the head hanging that from the table, and the head it is around 30 degree. Wait for 30 seconds to 1 minute, and if he or she or any other gender gets vertigo and nystagmus, then she must be having BPPV. Now, if I ask you a question, do you think she will have any kind of hearing loss and stuff? What do you think? Like, if I show you, so the otoconia is displaced into the semicircular canal. That means something with the vestibular system, it is the problem. So is there anything with the cochlea? What does cochlea do? Cochlea has its own job, that is to transmit the sound into electrical forms to the brain. So sound is not affected. The person will be able to hear properly everything. There is no damage to the cochlear system. That means there is no hearing loss. Only thing is happening here is the vertigo. Alright, so did you understand? So why is the vertigo happening and how it is happening? Because the motive of this maneuver was to trigger the vertigo by making her in a certain position that will trigger the vertigo. Okay, so that's what. So she will have nystagmus and vertigo. Why? Because the motive of doing this maneuver is to manually dislodge the otoconia and send into posterior semicircular canal. Now, what kind of nystagmus? It is upbeating kind of. That means the eyes will go up, and it is also a kind of torsional. That means rotating, something like this and like this. Okay, it is shown in the arrows. Are there any other types of nystagmus? Yes. If the otoconia is in the posterior canal, there is upbeating type of nystagmus. If it is entering into the horizontal canal, it is horizontal kind. If it is entering into the superior canal, it is downbeating kind of nystagmus. Alright. So congrats. We are successful in giving her nystagmus by sending her otoconia in her posterior semicircular canal. By what method? By Dix Hallpike method. Now, let's understand about why nystagmus happen. Like, what is nystagmus? Nystagmus happens because there is abnormal signaling from the cupula. What is cupula? Cupula is this thing. This thing is present where? This thing is present in the semicircular canals. So, because of the abnormal flow of the endolymph or the otoconia that was dislodged, it can go and enter into the ampulla also. There it can go and bind to the cupula. Now, the cupula, they do not usually have these crystals of calcium carbonate. Okay, see, you can see here. It is all clear. There is no crystals or no debris or anything. But if this goes into semicircular canal and enters and attaches to the cupula, now this weight will become more. There will be gravitational effect on this. So will this be able to work properly? No, right? So there will be abnormal signal firing from here. Okay. So that was about the cupula. So let's now understand about what is nystagmus, like how nystagmus happens. Okay, so let's go back to the physiology and understand little bit about vestibulo-occular reflex. Now I will just give like simple basic understanding of how the things are happening, but then I will try to make another detailed separate dedicated video for vestibulo-occular reflex. Okay, for now, just to understand like what is nystagmus, if you don't know, then this might help you. So for example, let's say if my right posterior semicircular canal, okay, which one? Right one. So right posterior semicircular canal endolymph flows abnormally due to dislodged otoconia. Okay, now because of this dislodged otoconia, there will be abnormal flow of endolymph in my semicircular canals, right? Now because of this abnormal flow of the endolymph, like however the endolymph will move, if it moves like this, the hair cells will bend like this. If it moves like this, the hair cells will bend like this. So however it bends, whenever there is bending of these hair cells, there will be signals generated. They will fire the signals. Now these signals will be carried by my right vestibular nerve. Why? Because my right side there is a problem, right? So right vestibular nerve will carry to the brain. And what happens here? Why is the nystagmus? Nystagmus is because the brain thinks, the brain interprets, and the brain thinks ki, oh, the head is rotating, I guess, because I am getting signals from the right vestibular nerve. Although it is not proper signals, like it is not actually because of the rotation of my head, but the right ear, because there is some problem with the otoconia and the endolymph, there is signals generated, right? That is why brain thinks, oh, the head is rotating. So what will brain do? brain will try to correct it. Correct it means what? Correct it means here he is talking about the eyes. See, generally what happens is, let me explain you. So if this is, let's suppose, okay, hold on, let's suppose this is my face, alright, and this is my eyes, and here is my ear, here is my ear. So the ear takes signals like this, and from the brain the signal is received to the eyes. That is why this is called as vestibular means the ear, the inner ear vestibular system. Ocular means eyes. So these two together, the system together is called as vestibulo-occular reflex. Now in this what happens is, you can try it out. You look at the screen, okay, you fix your gaze at this screen. Let's make a point. So I am making a point. You fix your gaze at this point and try to move your head right side or left side or up or down or cross, anywhere, but fix the gaze to this point. What do you think is happening? Although your head is moving maybe like this, but your eyes are at this point. That means your eyes are moving opposite. You're getting my point? So whenever you fix your gaze and you try to move your head in any way, so opposite to that your eyes will move, so that the eyes is always in a central position, and that is what brain does. The brain wants to stabilize the eye no matter how you move, until or unless you yourself move your eyes here and there, but automatically the brain moves your eyes in the opposite to your head direction. Did you understand? Did you do this? So you just look up or down or left side or right side, your eyes is at this fixed position. Because now let me just draw a simple diagram for you. Let's suppose this is graph, okay. So if your head is moving something like this in a sine wave, your eyes will move in opposite direction, okay, in a cosine wave. This looks like a DNA, but whatever, I hope you understood. So if your head is moving upward, your eyes will move downward. If your head is moving left side, your eyes will move towards right side. So this is what the vestibulo-occular reflex does. It stabilizes. So same thing is happening here. When there is disturbance in my semicircular canal, the endolymph flow is abnormal because of the dislodged otoconia. There is firing of the hair cells, okay, and these signals will be carried to my brain, and the brain will think, oh, the head is rotating, then okay, let me do this, let me correct it. Correct what? Correct the eyes. So I should reflexly move the eyes in the opposite direction. So if you are turning right side, your eyes are turning left side. Why? To fix the gaze or to stabilize the eyesight or vision, or that, what is that thing? The field of view, okay. So because of this mismatch between the vestibular system and the visual system, there is vertigo. Okay, you got my point. Why is there vertigo? Vertigo means what? There is rapid eye movement. The eye is moving rapidly, like this, like this, like this, like this, okay, or like this, whatever. So because of this, because the brain thinks the head is moving in one direction, that is why the brain wants to reflexly correct it and brings the eye opposite direction. Okay, you're getting my point. So there are two phases. One is the slow phase, the other one is fast phase. What is slow phase? The slow phase is nothing but the corrective phase that is done by the brain. This is what the brain thinks the head position is in apparent, like the apparent position. Like he thinks that the head is moving, but actually it is not moving. That false signal is produced by whom? Produced by the vestibular nerve, because of that abnormal flow and hair cells. Okay, so this is like apparent position where the brain thinks that is the real thing, but that is not. You are getting my point or not? Okay, so this is the corrective movement, which is the slow phase. But the CNS tries to keep the eyes in the central position, hence the eyes suddenly snaps back, because that is where you were supposed to look. You are looking. So that is the fast phase. So there will be two phases. One is slow phase, the other one is fast phase. Of what? Of nystagmus. Okay. So this we discussed little bit about vestibulo-occular reflex also. And as I said, this I will make a dedicated video, okay, because I don't want to unnecessarily increase the length of the video. For some reason, no matter how much I try, all my videos are going in more length. So I don't know how do I manage that thing. Anyways, so we understood what? We understood the diagnostic investigation, that is Dix Hallpike maneuver. We understood that we are manually, or we are triggering the vertigo and nystagmus by manually dislodging the otoconia and sending it into the semicircular canal. Now, I understood that okay, this patient has BPPV, that is benign paroxysmal positional vertigo. So what is the treatment here? Now, as I told you to remember that thing, when I told you that it is custom made. What is custom made? The crystals of the calcium carbonate. It is biomineralized, custom made. Now custom made means what? What I am trying to say here is, so in the fetus, when we were forming, our body was forming, so our bones and everything was also forming. Similarly, these crystals were also forming. But if you might have a question, so they are just bunch of calcium carbonate crystals, right? So if they are dislodged and if they are going here and there, let them go. Can't we give bunch of calcium tablets or somehow calcium carbonate tablets or anything, so that it can regenerate here? Or maybe our body is so sophisticated and it is the what do you say, the most sophisticated machine in the universe. Can't it just regenerate these crystals of calcium carbonate? Big question mark, right? So no, it cannot. That is why I am telling you repeatedly that it is custom made. It is for the special purposes. It cannot be remade. Just like how we have custom bikes and custom cars and everything. Okay, it's like one in a million, or it is something special. So the body cannot regenerate, or it cannot make, or you cannot send calcium from outside into the vestibular system, and it does not just go and deposit. Because one thing is, the vestibular system and the cochlear system, first of all, it is very tightly regulated means what? That means even the immune system cannot enter into these organs. Okay, so they are very much isolated from the rest of the body, just like the eye lens. Then even the brain has blood-brain barrier. Then there is testes. Okay, so these are a few special organs which does not allow immune cells to go into their environment just like that. Okay, until or unless there is heavy need of them or something. So they are very much isolated. Okay, why I am telling this is because you might think ki our bone has bunch of calcium carbonates. Okay, but cannot the bones send a little bit of calcium carbonates into the inner ear just as a replacement? Is the bone selfish or what? But it's not like that, no, because these crystals are very special. They are, you can say, either custom made or precisely crafted only for this purpose in the inner ear. So the calcium, if you this doesn't happen. Okay, if you're giving calcium from outside also, it cannot enter, it does not happen like that. So that is why there is no treatment, you cannot, there is no oral treatment or calcium therapy or something. So we have one thing, that is the another kind of maneuver. It is called as Epley's maneuver. What is the spelling? Epley. Okay, Epley's maneuver. So what is Epley's maneuver? What are we doing here? It is a 5-step procedure, or 5 steps. There are 5 steps. What are these 5 steps? So first, come this side. First you understand here. So this is just like extension of the Dix Hallpike maneuver. In Dix Hallpike maneuver, what did we do? So there was a patient here. He was sitting like this. Then you turn his face towards 45 and make him lie down with an angle from the from the table at around 30 degree. Okay, this much you did. This much is in the Dix Hallpike method, same as like this only. Okay, so what is extra here is, once you done like this, then you rotate his head first 90 degree looking straight upwards, then again 90 degree on the opposite side. So it is from here 180 degree opposite. Okay, so you did that. After that you come here. See, first she turned his face 90 degree towards this side, then towards the opposite side. So initially she turned the head towards the affected side. This is the affected side, and then you turn it opposite 180 degree to that is non-affected ear, that is the good ear, healthy ear. After that, what you will do, you will tell him ki you turn your entire body towards that side, and at that point this person will look or should look straight to the floor, okay, downside. So then rotate entire body in the same direction and then make him sit upright, and then tell him to fuck off. So you're getting my point. Until here it is the Dix Hallpike method. So same thing is written here, you can see. So same thing is written here also. So first the person is standing something like this. So here is the dislodged otoconia. Then he is lying down with angle 30 degree. This is the affected side, okay. So this comes from here to here at this position. Then you tell him to go opposite, to look opposite side, that is 180 degree turn. So this will go at this position. Then you tell him to look down like this, okay, and tell him to move his entire body towards this side, and he should be looking at the floor. So see how this otoconia is slowly coming into the utricle. So then this comes like this, and at the end when he sit upright, this will enter into the utricle, that is his home. Whose home? The otoconia's. Okay, this is where it should belong, and not wander here and there in the semicircular canal, because what will happen? Vertigo and nystagmus will happen. Okay, so these are the steps, position 1, 2, 3, 4, 5. You can just look it later. And at last we have the other kind of maneuvers. So other named maneuvers are like, for the posterior canal we have the Epley's method that we just seen now. Then there is one more method called a Semon's method. For the horizontal canal we have the Guffonis maneuver and the Lempert's maneuver. And for the superior canal we have the deep head hanging method. Alright, so what did we discuss? We discussed about the benign paroxysmal positional vertigo. Here it is not a very dangerous disease or disorder. It is transient vertigo, like for 30 seconds. And this happens due to if you are at certain positions only, like if you suddenly wake up from sleep, okay, then you might feel vertigo, or in any other position which might trigger vertigo. It is not any disease which will kill you or something. So there are these otoconia which are present normally on the macula of the utricle. This gets dislodged into the semicircular canal, mostly in the posterior one, and these are the etiology. And because of this there will be vertigo, because of the abnormal sensations sent by the vestibular nerve into the brain, which thinks ki head is in different direction. Because of that the brain will recorrect the eye position. It will bring back the eye, or reflexly it will try to move the eye backwards or opposite to the whatever the direction the head is in moving. Okay, so diagnostic investigation is Dix Hallpike method, and for the treatment we have the Epley's maneuver. So we are done with the benign paroxysmal positional vertigo. These are the other. So next we will be discussing about vestibular neuritis, labyrinthitis, and these are the other peripheral vestibular diseases, and these are the central vestibular disorders. Okay, so this happens due to the inner ear problem, and this happens due to something with the CNS problem. Now as we have finished the lecture, I will remind you to do this homework. Okay, you download the PDF. I will be giving this in the description. You download it, you solve all these questions. So yeah, that's all.